going to launch straight into the questions that we have already been sent to us. What causes morning migraine attacks?
A number of things. If you have headaches in the morning, it can be, other things besides migraine. Sometimes it might be clenching your teeth, and it could be a TMJ issue. It could be that it's a sleep issue like sleep apnea. It could be that you're experiencing something that's slightly different than migraine called intracranial hypertension, where some people have issues with high spinal fluid pressure, and laying down actually triggers headaches and can be associated with a lot of other medical complications, even potentially blindness that's irreversible. So let your doctor know if you're waking up with headaches, if headaches are waking you up, or if things are worse in the morning.
Absolutely. Great answer. Short and sweet, to the point. Obviously, there's a lot more information there that you could have shared, and I will just say and keep my comments short that my morning migraine attacks are the absolute worst because they're often already full blown. And so when you wake up at 3, 4, 5 in the morning, you can't even see, or you're throwing up. It's just a nightmare situation. If you are new to our community, let us assure you that you are not alone in going through this. These are really challenging attacks. So the next question, this is a really hot topic. How do you find a doctor that will listen? Bearing in mind that there are less than 1,000 certified headache specialists in the US.
I would even argue that there are some people that are headache specialists that may know everything in the textbook, but still may not necessarily have everything that you're particularly looking for. Sometimes personalities don't always, mesh perfectly. A lot of it really, should have to do with the credentials that people have. So like you mentioned, board certification, fellowship training, those things help. If you're able to get a good recommendation from people that you know, or from good resources, even online, even some of, the work that you do at Migraine Meanderings, I think that, patients can sometimes share not just what's worked for them, but who's worked for them.
Right. Absolutely. Absolutely. Thank you for that. And yes, sometimes just because you have all the education and knowledge doesn't necessarily mean that you are good at listening. And it's really important to find a doctor who will partner with you and who will listen. So, and that's hard for so many patients to find someone who is like that. So question number 3, why is there not a better understanding of migraine and how to stop them within the medical community?
To tell the truth, most medical schools have less than an hour of training on headache at all. And a lot of it has to do with the fact that migraine itself, headaches, are very common. Basically, we say 99+% of all human beings experience them. And for that reason, even though people know that they can sometimes be a harbinger of a very serious condition, and sometimes they even understand that there can be people that are disabled by migraine or other headache conditions, they don't always have that background. We're, taught literally for weeks on end about, specific biochemistry, ideas and formulas that we have to memorize. And sometimes we don't get the perspective on the most common, so I would argue most important aspects in medicine.
Right, absolutely. So kind of an adjunct question to that would be, what can we as patients or as people who live with migraine do to help turn that around?
Advocacy, absolutely, more than anything. Making sure that people do know your story, making sure that you're, and getting yourself, to, advocate, to tell your story better. You can tell your story better than just about anyone else. There are great advocacy organizations, and, even just being part of a community like Migraine Meanderings is helpful. Sometimes even going a little bit beyond it. One thing that one of my mentors prescribes for a lot of his patients is advocacy, going to Headache on the Hill, and sometimes even local advocacy. When there are, school board, elections, sometimes that's what can determine whether, even high school kids can be, what their policies with regards to concussion, head trauma, absences, from school. These are important issues. So, educating yourself on what's going on, even slightly outside the community and advocating.
Right, absolutely. Definitely advocating for yourself is and for others is such a huge thing. And fighting for your rights. I think there's so much stigma
Right.
around migraine that we tend not to fight for our rights. So we just kind of put up with the stigma and with the bias against us. But it's so important that we all fight, for what we need to have, whether it's an insurance company, a doctor, at school, at work. And I think all of those little things together with some of the greater, I shouldn't say the greater forms of advocacy, but the more complex ones where you're looking at policy change, all that stuff together makes a difference. And if we all do something small, then those little ripples will become something really big. And that's the goal. But it can really be frustrating. Completely different topic. And a lot of these questions are just very general ones to begin with. And a quick reminder for anyone who's just recently joined us, if you have a question, please put it in the comments. We have a lot of questions to get through. But if you do have a live question, we will absolutely do our best to ask it. So please put whatever your thoughts are in the comments and we will definitely get to you. So, is it common for your ears and face to turn red during a vestibular migraine attack?
I would not use the word common. It can happen. There are specific headache conditions that have what we call autonomic features, which is where you can have flushing or sometimes tearing or sometimes, runny nose or ear pressure, eyelid drooping. There are a whole host of these autonomic symptoms that can happen. And like I said, in specific conditions, specific headaches, we definitely see those as a hallmark. That being said, somewhere between probably 10 to 25% of people will experience those autonomic features even with migraine. So it doesn't have to necessarily be vestibular migraine. Even your run-of-the-mill episodic migraine attacks can have autonomic features. The unique kinds of headaches, that's where it happens specifically on one side and one side only. When it's migraine, it will usually vary, or if you have pain on both sides, it can even happen on both sides.
Absolutely. Super helpful to know. And there are so many symptoms in migraine that it can be complex to cover all of them. So another one, which is actually a question further on down, but I'm going to jump to it now, is about autologic symptoms. And the person who asked the question actually asked about autologic migraine, but I believe what they're referring to is autologic symptoms during a migraine attack. So maybe you could quickly go through what those might be and how common they are.
Yeah, otologic means ear symptoms. And I wouldn't say also that ear symptoms are very common with migraine, although some people may experience them. Probably the most common ear symptom with migraine would be pain on the same side. If you're going to have, headache pain, pain in the temple, you can also have pain. Most people will, describe pain behind the eye. Some people will even describe pain behind the ear. So ear pain can be a symptom. Tinnitus or high-pitched ringing of the ears can happen sometimes also not uncommon. I'd say those are probably the most common symptoms. We mentioned autonomic features, so that's where the skin outside the ear can be flush, or sometimes ear pressure. Those would be considered autonomic symptoms. That being said, oftentimes if you experience anything like that, we do want you to get evaluated by an ENT specialist.
Yep.
Certainly have some imaging to make sure that there isn't some other secondary cause to those ear symptoms also, because they are not common.
Right. Absolutely. And especially if someone's getting something that's new that hasn't already been evaluated, presumably. Right. It's important to get checked out. Talk to your doctor about that. Next question is, why does cold air blowing on your face cause migraine? I was kind of interested by this question because coming from windy, cold England, I always found being out in the wind would trigger a migraine. So, why does that happen? And again, how common is that?
Mm-hmm. It can happen. I also wouldn't necessarily say of, the triggers that we think about. It's not necessarily a very common trigger. It is a very common trigger for another condition that we're going to talk about a little later called trigeminal neuralgia. I would even go so far as to say it can be a hallmark of trigeminal neuralgia. Air or the wind blowing on that area and really worsening symptoms. Now, why would that be the case? When you are experiencing migraine, especially if it's more chronic migraine, you will even have irritation of some of the more superficial nerves around the head and the face, all the little, small nerve branches and nerve endings, and further irritation can worsen it even more. A lot of times people will even describe, let's say, light sensitivity as a trigger. Oftentimes it's an associated symptom and you just need that last little bit of light sensitivity
right.
to then lead to a migraine attack. Similarly over here, you might be sensitive to, different feelings right around there. Those nerves are almost ready to go, and the wind comes,
That's it.
cuts off an attack.
Yeah, that makes total sense. Okay, we have a live question I'm going to ask at this point in time. So any theories on why the newer CGRP meds will work well for a period of time and then stop working? I know that there's been some research on this. I know it's discussed at AHS meetings, but what is the latest theory about that, or do we know yet?
I think it really varies from person to person. Anytime it is an injectable or monoclonal antibody, type medication, it's possible for you eventually to develop neutralizing antibodies to those antibodies. Right. Can happen. And other, biologic type medications, other monoclonal antibodies, these things happen, I'd say, fairly frequently, where somebody might be on a medication like Humira or some other injectable type medicine, and sometimes they have to switch to another one over time. When it comes to the orals, we're not seeing that much, development of, let's say, a tolerance to those medications. That being said, sometimes the reason why things worsen may not necessarily be because of the medication. It may be that there's an outside factor that's actually worsening migraine also. So it may be despite the fact that the medication is trying to do everything that it's supposed to do, as opposed to, a problem with the medicine.
Absolutely. And I know I experienced that with the preventive medication I'm on, and trying to figure out, is it that it stops working and I need to take a medication vacation from it for a while before going back? Or is it that I'm just going through a bad phase? And it can be really hard, if not impossible, to know sometimes, what is going on. But I know that with the injectables, we're seeing a fair amount of conversation in our groups about medications working really, really well. And then it's been radical that they've just stopped. And so it's obviously discouraging for people. That brings us on to another live question, which is, why does migraine seem to change in frequency and features throughout our life, and even, from just attack to attack?
It's a fantastic question. The reason why is because we don't really live in a vacuum. We live in real life where there are so many factors that can influence migraine attacks on any given day. It can be, how well you slept the night before. It can be what you just ate. It can be what the weather and the humidity is like and the barometric pressure dropping. It can be, the different things that you're going through in your life and what your stress level is at. And, when it comes to, estrogen, hormonal, fluctuations also, these are things that change, throughout your life. And all of these things influence migraine in different ways. That's really why migraine is not always something that's very stereotyped. It changes over time.
Absolutely. Great answer. Thank you. Thank you so much for keeping the answers short. I know that you were commenting before we went live that you could talk for an hour on each of these questions. And I know that you could. We're going to have a great conversation out of each of these. So this is just a different format for those people who want more detail for each question. This is just a open mic session where we are definitively trying to keep it short and sweet. But there are a ton of resources on our website, migraine-meanderings.com. Also, if you go to neurahealth.co, they have a lot of resources as well. And of course, there are other advocacy organizations that have great resources. So we can always dig deeper. And if a topic is is of a lot of interest to this community, we'll have Dr. Berk come back and we will dig more into that particular topic. Talking about another symptom, sharp pain in the eyes. So sometimes people will describe it as ice pick, which may or may not be ice pick, quote unquote, headache. It could just be pain behind the eyes. Again, how common is this? When would that be a cause for concern versus just a symptom of your migraine?
I would say it would be a cause of concern if, in addition to the actual pain itself, there are also vision changes or certainly vision loss associated. So painful vision loss to me is a major red flag. If you describe this to your doctor, the first question that they're going to ask is, when is the last time you were seen by your ophthalmologist? You do want to make sure that there isn't some other condition that could be playing a role. Right now, I'm wearing my glasses because I'm experiencing a bout of dry eye. And sometimes that can also, worsen the migraine attacks and pain that you have. And in addition to your headache getting worse, sometimes the pain in your eye that's, underlying things can also be getting worse.
Absolutely. Right answer. Thank you. Next question is, are there ways to prevent or combat migraine fatigue? I mean, that would be amazing if there was. And I'm not sure if the question was specifically about a migraine attack or just like migraine in general, because it can also be an interictal symptom. So any great ideas for that other than just managing migraine overall?
It really varies person to person. And if you bring up fatigue to your specialist, they're going to definitely look at certain vitamin deficiencies and hormone, tests. They'll look at your thyroid. They'll look at your vitamin B12 and your vitamin D. They'll look to make sure that you're not anemic. They'll ask you lots of questions about your sleep, because sometimes that can be playing a significant role. We talked about waking up in the morning and having more morning pain. Sometimes sleep apnea or other sleep issues can be playing a role and causing a lot of fatigue and worsening your migraine too. So sometimes it's migraine fatigue, and sometimes it's fatigue that's worsening migraine.
Right, absolutely. And I know fatigue can be really exhausting. I would just add one thing to that, and that is that for people with migraine, we feel like we lose so much of our life to the attacks. And so we will push through, and self-care becomes a lower priority. But pushing through constantly can also just increase fatigue, right? And so that self-care is really crucial, even though it's challenging to do. So what is the difference between intractable chronic daily migraine and status migrainosis? And I know that you've spoken about this at length in the past of a video, but in a nutshell, how would you define the difference? Is there a difference?
There is. Status migrainosis is an individual migraine attack lasting more than 72 hours. Chronic migraine is somebody who experiences very frequent attacks, so frequent that they are 15 plus days per month. And on the majority of those days, there are features of migraine. So you're not necessarily experiencing a migraine attack that's very prolonged. You can have both. You could be somebody who has chronic migraine and status migrainosis.
Right. Absolutely. Thank you. That's a really great way of clarifying it. Next question is, can a history of migraine since childhood and modern treatments in adulthood increase the risk of dementia and Alzheimer's? Are there any studies in the works? The only thing I'm going to add to this before you answer is, obviously we had one of the Neura Health doctors come and talk about this, and his presentation was that there is a link to it. I know at AHS, I think earlier this year, there was a discussion because some people say yes, there is, and some people say no, there isn't. What are your thoughts on that?
I think it's very much up to debate. You mentioned the last American Headache Society meeting. It was the scientific conference in Austin, where we got a chance to see each other. And the big debate was, there were two, leaders in the field that took, two varying sides. There isn't anything conclusive. That is basically the bottom line. Can there be, an association? We know that the T2 flare hyperintensities that people have with migraine, those little white spots that your doctor might describe when they say, we took a look at your brain, we see these little white spots. Those do not seem to be associated with experiencing dementia. The migraine medications themselves, for the most part, don't seem to be associated with dementia. The one question would be tricyclic antidepressants, the TCAs, like amitriptyline and nortriptyline. Very big question mark, because there may be an association. Precisely how, we're not entirely sure. Very likely, if you're on it at a certain point, certainly early on in your life, it doesn't seem to be something that's a risk factor. If you're on it when you're older, if you're on it for years or certainly decades, it might be. So there's a lot that we don't know. There are trends that we are looking at, and yes, there's a lot of research that is trying to more definitively, quantify what the risk seems to be. You can argue either side of this very, very strongly.
Right. Absolutely. Great to know. Like anything else, migraine, it's complex, and there's so much that we don't know yet. But fortunately, a lot of research going on for all these things. Is there any clinical evidence that supports common treatments for central sensitization for migraine? Maybe we should take a step back, and you could give a quick definition of what central sensitization is, and then any treatments like CBT, yoga, biofeedback, etc., that may help.
Absolutely. Central sensitization basically is a situation where the pain matrix, the structures deep in the brain that are getting all of the sensory input, because they're so used to getting input that describes pain, basically consistently feel and respond to pain, even if there isn't pain that's happening in that area right then. So that's the idea of central sensitization. Are there specific treatments? None that have, I would say, ever been studied with randomized controlled trials, although there is evidence for specific migraine treatments that may also help central sensitization, like Botox. There's definitely evidence for that. Question with regards to some of the CGRP antagonists, the monoclonal antibodies, it's possible, but very, very small studies. With regards to non-medical treatments and therapies like CBT, anecdotally, I'll definitely tell you that there can be benefit to it. Although, like I said before, these things haven't been studied with the same rigor that we would study many other kinds of treatments or many other conditions.
Right, absolutely. That's really helpful. And I know that later on this year, we have one of the care coaches from Neura Health come in and talking about biofeedback specifically. So we'll be able to dig more into that aspect of it later this year, which is going to be really helpful. Next question is going to be, what causes allodynia while experiencing migraine and in between attacks during the interictal period? And maybe you could give a quick definition for what allodynia is as well.
Yeah, this is fantastic to have these back to back. Allodynia is that next step from central sensitization. When your brain is so used to getting, pain signals, if there's a stimulation to your scalp, to some area, and your brain perceives that as painful, that is allodynia. You can sometimes have that in migraine during an attack. You can sometimes have it if you have chronic migraine and what we call interictal, which means in periods between the attack. Oftentimes people with chronic migraine will experience something in between their attacks. They won't necessarily often be able to get down to an absolute zero at their baseline, 0 out of 10, no pain whatsoever. And allodynia can be one of those symptoms that still lingers.
Right. So in terms of that's helpful in terms of trying to manage allodynia. One person talked about the intense itch. I mean, I don't have intense itching, but I have a lot of pain in my head and my face and my ears, which I'm presuming is probably allodynia. What's the best way to deal with it? Is it the same as, does it literally go hand in hand with central sensitization? As in, as you deal with the central sensitization, allodynia will come down? Or is it like once you have it, you have it?
I wouldn't say once you have it, it's there forever. I would say focusing, because it's a manifestation of the central sensitization,
Right.
focusing on that to an extent, certainly discussing it with your headache specialist and trying to address it one way or the other likely will help the allodynia also.
Absolutely. That's super helpful. Another question actually just came in live. I know that this could be like a whole hour and more. How does serotonin impact migraine?
Yeah, absolutely. This could be an entire series of
Right.
lectures, to be honest. With regards to serotonin specifically, it isn't so much that it's a one-to-one relationship between low serotonin and migraine. Here is what we know, and this is complicated, and it may take me more than a minute to kind of
No worries.
through. But what I would say, first of all, is we know that people who have migraine during an attack, people with chronic migraine even between attacks, do have alterations in many of the neurotransmitters in their brain. We can see that in CSF studies. We can actually test levels of many specific neurotransmitters in the brain. Serum neurotransmitter levels are a little bit more difficult to define. In other words, just getting it from your blood, the reason why is because there is a difference between these, what you would find in your brain and in the blood. There's the blood-brain barrier itself, and these things wouldn't necessarily correlate. When we look at metabolism studies on what we call fMRI, so it's more looking beyond the structure of the brain, but at functional usage of parts of the brain. We do see that in people who, like I said, have chronic migraine or during a migraine attack, there's hypometabolism in certain areas that are in charge of regulating serotonin and other neurotransmitters. We know that focusing just on serotonin really doesn't help migraine that much. So most SSRI medications don't really seem to be very effective at migraine prevention. Other antidepressant type medications that work on serotonin and other neurotransmitters, for instance, SNRI medications, those work on serotonin and norepinephrine. We mentioned the tricyclic antidepressants,
Right.
those work on a whole host of other neurotransmitters, and serotonin to an extent seems to be much more effective at preventing migraine and decreasing the frequency and the severity.
Right.
One interesting thing is triptan medications, which were the first migraine-specific acute treatments that were ever developed, are all serotonin receptor agonists. So they specifically turn on a serotonin receptor. And by doing that, they're able to actually stop an attack acutely. So the answer is it's complicated, but we know that all of these are important pieces to kind of understand how serotonin influences migraine in various ways.
Thank you. That's really helpful. So I'm going to add a question of my own, and that would be for people who may have responded really well to tricyclic antidepressants in the past, and also responded well to like sumatriptan, whether or not they're still able to take it. Is that an indication? You may not know the answer to this, but is that an indication that medications that directly impact serotonin in that way would be more successful for them versus other medications, or is there not necessarily a rhyme or reason to it?
I wouldn't necessarily say that they're predictive. Sometimes, I mean, obviously it tells you something, and when you're in a discussion with your specialist, that's going to want to make them think, is there something that can kind of bridge this gap? Is there something similar that you can focus on that might also be helpful? That really isn't, like I said, predictive, and it wouldn't guarantee that other treatment would be helpful, but sometimes it's enough to influence the next option and the next choice with regards to treatment.
That makes total sense. And we're going to talk about biomarkers a little bit later. In fact, in a few questions. But we have some questions coming in thick and fast right now. We're not quite halfway through, but we're doing pretty well, I would say, speed-wise. So why are photophobia and phonophobia so common with migraine? What's going on in the brain? In
Absolutely.
60 seconds.
I think that the short answer is, just like we have activation of those little nerve endings that I talked about in the face and in the head during a migraine attack, there are little nerve endings also in the back of your eyes, in your inner ears, even around the nausea centers of your brain, something that's called periaqueductal gray. And that activation makes those little nerve endings irritable, makes them very sensitive when something comes and disturbs them even further. That's why those are some of the most common associated symptoms with migraine.
Interesting. Okay. Thank you for that. I appreciate it. Again, I know that's like a whole topic in and of itself, so it'd be fascinating. Next question I have here, and I'm going to get to some more live questions that have come in, is someone asked about a transformed migraine. Can you explain what a transformed migraine is? And is it essentially just episodic migraine turned chronic?
It's an old term that we don't really use so much anymore. Basically, it means somebody that used to have episodic migraine, and for whatever reason, sometimes there are obvious reasons, sometimes not. It can be due to medication. It can be due to injury and head trauma. It can be due to, a million other factors, hormonal or, psychological. Eventually, the headache frequency, not immediately, but slowly over time, increases to the extent that they now have a diagnosis of chronic migraine.
Right. Perfect. Thank you so much for that. I appreciate that. Sometimes it seems to me, and I may not be correct, but sometimes it seems that that you can tell how much current education a doctor has on headache medicine by the terminology that they use. And maybe I'm treading on dodgy ground here, but sometimes we hear terms that seem very, very old. And so it makes me wonder, is that person, up with the most current education? Maybe that's something you're not comfortable commenting on, but is that maybe we should just pass on that. We'll just leave that as a comment that I made, unless you feel like it's something you should comment on.
I think that some people are, I would definitely say sometimes older school, neurologists, even people who have a lot of knowledge will use the terms that they've used for so long, either because of endearment, maybe they coined the term themselves. So I wouldn't necessarily say that's a hard and fast rule, but you will definitely get a good sense of a specialist's knowledge based on how they describe, sometimes not so much like the specific terminology or specific words, and how they seem to internalize and understand migraine.
Right, absolutely. That makes sense. We definitely hear some unusual terms like cluster migraine, where it seems like they're mixing diagnoses. And so some of those things can be or autologic migraine, and that can be indicative, right, of something. So a question here. So someone who's live with us right now says they've had intractable migraine since May 22. There's specialist things that may be hormonal. Obviously, we know you can't give personal medical advice, but if the migraine was hormonal, then would there be variations in it, or would it just be is it more likely to be just a constant level?
So there are two different kinds of what we would describe as menstrual migraine. One is somebody who has purely menstrual migraine, where really the only time they ever experience migraine attacks is right around their menstrual period, and they're also allowed to have it the day before or during ovulation. So two specific times during the month. And if you're not sure, you can even use an ovulation calendar, or there are specific tests that you can use to really figure out if that's the case. There is menstrual migraine that's not pure menstrual migraine that can be there if you have chronic migraine. It can be episodic migraine. Anyone who experiences multiple other triggers, and hormonal factors are one of them, will also have that diagnosis of menstrual migraine. If you have menstrual migraine, is it possible to have also a headache every single day or very frequently? Yes, you can have chronic migraine and menstrual migraine. So that's what I would say specifically for that. How would you tell if it worsens or if there are different features to the migraine right around those specific periods of the month?
Right. That makes total sense. And I know that we were originally going to be having Dr. Yablon talking today, and you kindly stepped in because that wasn't able to happen, but specifically about hormones and migraine. And so we're hoping to have Dr. Yablon later this year, beginning of next year, for those who are listening and are specifically interested in the hormonal interaction with migraine, not just, in early childhood or middle age, but like perimenopause, which can be extremely tumultuous hormonally and just kind of sometimes send migraine just off the charts. So next question is this another live question. Is there any association between migraine and autoimmune disease? I sense that this is going to be another controversial topic that some people disagree with, but what is your understanding of that?
Migraine is associated with very many other conditions, and the question is, to what extent having migraine doesn't necessarily put you at a higher risk for autoimmune conditions. Migraine is not necessarily thought to be an autoimmune condition itself, but we do see a lot of overlap. Precisely how, I think we'll be able to talk a little bit when we get to that biomarker question, but there isn't a direct correlation, but there does seem to be some overlap.
Right. So it's not that one is causative of the other necessarily, but there do seem to be clusters of comorbidities, for example,
Correct.
right? So let's get on to that question, which is, and this is a question for me because I'm always fascinated about it. I actually went to a webinar by US Pain Foundation earlier this week that was all about chronic low back pain, and phase 2 study right now on phenotyping, and the holy grail being determining what treatment options are going to work best for which people. So where is that for in the migraine world? What level are we at? I know there's been research on genes, but where are we at in terms of phenotyping and biomarkers and just knowing ahead of time a better chance of which treatment will help which person?
I think the two most important studies on the migraine side that have looked at this, one is a study by Will Renthal at Mass General, who actually recognized almost 200 different genes associated with migraine. and another very important study by Dr. Richard Lipton at Montefiore that was able to kind of look at, like you mentioned, clusters of migraine and how they present. And he described 8 specific kinds of phenotypes of migraine, and whether it's migraine with more vascular features, migraine with more joint pain, migraine with depression and anxiety, more mood presentations, and 8 specific kinds of clusters. Now, what we really need to do is something that bridges the gap of knowledge. And, there is research that's looking into that, but to date, that's really kind of what we're up to. We have genes, we have genotypes, we have phenotypes, and we're trying to piece everything together.
Wow, it's fascinating. That's just an area that, for me, and I think for many of the rest of us, is fascinating. So many of us get anxious when we're looking at trying new medications, especially. And if we know that there's a greater chance that something may work for us because of this, I think some of that anxiety will lessen. And so it would be amazing, even if it doesn't happen in my lifetime, hopefully in my children's or grandchildren's lifetime. That's definitely the hope. So let's talk about one of those types of migraine, like hemiplegic migraine. And the live question here is there such a thing as migraine stroke? And if you have hemiplegic migraine, are you more likely to have a stroke?
First thing that I would say is if you have hemiplegic migraine, you definitely should get evaluated by a headache specialist to figure out if it's familial hemiplegic migraine, which likely would put you at somewhat of an increased risk for stroke. There are specific, even beyond familial hemiplegic migraine, other migraine plus genetic conditions that significantly put people at a high risk for stroke. It may be that what you're actually experiencing something that looks a lot like hemiplegic migraine, but isn't really that. I actually had an Instagram live last week with Dr. Courtney White from Jefferson where we talked specifically about many of these different presenting migraine,
Right.
aura and hemiplegic-like syndromes, things like MUMS, which is migraine with unilateral motor symptoms, and how to tell these things apart. Is there such a thing as migraine stroke? There can be. One of the reasons why, if you're experiencing migraine aura symptoms for greater than an hour, you want to get evaluated is because it is possible for migraine aura itself to actually lead to a cortical stroke. And that would be something we would definitely want to recognize. It would be something we want to investigate for, and something that theoretically we could treat, because when we talk about actual stroke and potentially irreversible consequences with the brain, that is a possibility. So definitely bring that up to your specialist if you're experiencing prolonged aura.
Absolutely. That's super helpful. Thank you. And I just, on a slightly different topic, but kind of the same, is that if you don't generally experience aura and you suddenly do in the middle of an attack, that's also something you should talk to your doctor about, because it may be aura, maybe something different, could be something, ophthalmic going on, or any change like that. You could look at the acronym SNOOP, which we have on our website. We also have on our Instagram. I'm sure Neura Health has it on your page as well. All the different reasons why you need to talk to a doctor sooner rather than later are going to be really important. So I have a question here from my moderator saying people are asking about barometric pressure and migraine. I'm still kind of watching the question being typed in, but I know we had a question here that was specifically about how to prevent attacks during weather events, or, if you're flying and the barometric pressure changes, what's the best way to approach that?
Something you definitely want to discuss, just like any other trigger, with your specialist. The best thing that can help prevent your attacks can prevent the attacks that are triggered, whether it's more by stress or hormonal fluctuations or, weather also. So definitely focusing on the best preventive treatment for you. This is something that I would definitely say hasn't been widely published, but it's more based on anecdotal evidence. There are, I'd say, more and more specialists that will sometimes give small doses of Diamox, which is acetazolamide. It's a medication that we use for altitude sickness. And some other, we mentioned, intracranial hypertension, some other, pressure kinds of situations, whether it's intracranial or barometric, and sometimes using that for, when you know that the barometric pressure is going to be changing, a storm is coming in, that can be an option.
Okay. Helpful. Thank you so much for that. Appreciate it. Okay, next question. We're going to get to the trigeminal neuralgia question, which is, are there any recommendations on co-managing migraine and trigeminal neuralgia? But let's also add migraine and occipital neuralgia.
Absolutely. Sometimes you want to make sure that what you're actually treating is, one condition versus two. Oftentimes you mentioned occipital neuralgia. It can actually be secondary to chronic migraine or sometimes chronic tension type headache. Arguably, I would definitely say there's some mentors of mine that would say occipital neuralgia by itself doesn't really exist. I wouldn't go so far as to say that. But if it is secondary to some other condition, you'd want to make sure that that underlying condition is treated most appropriately. When it comes to trigeminal neuralgia, usually that's not the case, although there can be other headache conditions that can involve the face and the head that may actually be more appropriate. And it may be that you're experiencing something like hemicrania continua, paroxysmal hemicrania, and not really migraine and trigeminal neuralgia together. That being said, there are some treatments that overlap when it comes to migraine and trigeminal neuralgia. The first line treatments for trigeminal neuralgia, for the most part, are anti-seizure type medicines that don't really help migraine that much. And most migraine medications won't necessarily directly help trigeminal neuralgia. If you are somebody that has both of these conditions, usually we will try to give you the best treatments that are most specific for the unique conditions that you have. And if you did need something that kind of did a little bit of both, sometimes certain muscle relaxants, if there's a prolonged exacerbation and you needed an acute treatment, sometimes that can be something that's helpful to an extent for both, but again, less specific. Some TCA and SNRI antidepressants can sometimes help both too. And again, a somewhat less specific migraine type treatment that can be helpful would be maybe gabapentin that could maybe help a little bit of both, but still not ideal for migraine, also not ideal for trigeminal neuralgia.
Perfect. Thank you. Another question that is very like treatment specific is, we know obviously that there's a bidirectional relationship between neck pain and migraine. So migraine can cause neck pain, but neck pain can also cause migraine. We know that a lot of people with migraine may also have actual issues with their neck separately. So we had a question from someone who had ACDF. And then obviously, myself, I have artificial discs in my neck. How do you approach migraine that is migraine by itself, but then it is also worsened by a pre-existing neck condition? Is there a different approach, or is it just muscle relaxers, or what do you generally do with that?
One thing we actually have is, 3 separate home, PT exercise programs that are specific for different underlying headache and neck conditions. We have, specific exercises that we typically recommend for people who have migraine versus tension type headache versus what we would call cervicogenic headache. And you might have a mixture of all of those. You definitely want to make sure that if this is a major issue, you have updated imaging, and sometimes in addition to anything that you're doing for the headache condition, you may separately need, whether it's injections, whether it's maybe even PT in person, something specific to address the neck issues. And sometimes those kinds of injections are deeper in the neck, and they're like epidural steroid injections or cervical branch blocks. Sometimes they're just trigger point injections that can, just be under the skin into spasmed muscle. Thinking about things that can help both. Sometimes, again, it would be more the TCA and SNRI type antidepressants, sometimes muscle relaxants, although, like I said before, they're a little less specific when it comes to migraine.
Right. That makes sense. And actually, it kind of brings us on to a question that was further on down on our list, which is about radiofrequency ablation. So sometimes, some headache specialists will recommend that. Some will not. This person was asking, why is it not a recommended treatment for migraine? But would it be true that if you have a neck condition where you're treating that neck condition, then that may, as a side effect, help migraine?
Yeah, I would say it really depends on what you're ablating, like you were kind of alluding to. If it's a neck issue and you have a significant disc herniation that's impinging on a nerve root, that would be a very different thing than somebody who's doing radiofrequency ablation on their occipital nerves. Occipital nerve ablation would be something that would not be recommended. Occipital nerve decompression surgery also would not be recommended. And most other surgical interventions for the headache would not be recommended, as per the American Headache Society's, position statement on
Perfect.
this from a few years ago. They basically allow for, research study enrollment, but they really recommend against anything more invasive, for headache. For neck issues, absolutely. Sometimes people need surgery on their neck, and will only fully be able to get their neck issues addressed that way.
Absolutely. And I'm just going to throw in a question there, because we've had a lot of comments in our group about migraine surgery per se, hot topic. And my understanding is that the AHS, the American Headache Society, does not recommend any of those migraine surgeries. But am I correct in that, or am I kind of off base?
No, you are correct. The American Headache Society has a policy statement from, I'm going to say, 2016, I think, 2017, that recommends against migraine surgery. And, I'll put that in quotes. The understanding of the people who are doing migraine surgery with regards to what actually happens in the brain during migraine is appalling. Unfortunately, many of the specialists that are doing the surgery have no background in neurology. Many of them are plastic surgeons. And when you even hear them describe what causes migraine, what is the process of migraine in their in the brain, they will talk about nerve compression outside of the head,
Right.
things that really are not associated with migraine whatsoever. One thing that I would definitely want to say is that there have been no randomized controlled trials that have looked at any migraine surgery. And even the paltry amount of evidence that people have, presented have not have any standards with regards to the outcomes that they're looking at. Pain freedom, at a certain point, reduction in migraine attacks versus headache attacks. They don't even most of the time describe the kind of headache that the patients were describing. These are people who weren't trained in even making a diagnosis, so you don't even know what the diagnosis of the half the patients that underwent the surgery is.
Right. Absolutely. Thank you for that. And it's good to hear it from you, because we try to say this in our group, but it's tough, because when people are desperate, we'll do desperate things. And I totally understand that. For myself, I always get very suspicious of any treatment, invasive or not, that claims to have an 80% success rate, 90% success rate, right? It just, a cure. It doesn't exist right now. So thank you for going there, even though it wasn't on our original list to ask. Have a live question here. Is there a connection between low levels of melatonin and migraine? And so if there is, should we be taking melatonin in place of or along with sleep aids?
There is no evidence that melatonin is associated with migraine. That being said, in the pediatric neurology literature, oftentimes melatonin will be given as an additional treatment, sometimes even preventively for migraine. The reason why is because oftentimes when it comes to kids, sleep regulation is so important for migraine prevention, and a very benign treatment can be melatonin in that situation. But long-term melatonin use is probably not going to be that helpful, to be honest.
Thank you. Appreciate that. Now, this is a really hot question. So we always hear, as people who live with migraine, that it's important to take our abortive or acute medication early on in the attack, sometimes even during prodrome. However, we also know that a lot of the medications have side effects, and a lot of them we are rationed because of our insurance. So the hot question is, how do we know when an attack is really going to need treatment versus an attack that may last for a short time or may just not be that severe?
Yeah, I think so many times patients are given mixed signals where they're told, on the one hand, treat early, on the other hand, don't treat so much. And you're like, what am I supposed to do? Like, which is it? The rule of thumb, I think, is you want to treat, when we say early, it's within the first 2 hours of an attack. And that usually gives you a good sense of, are things worsening? Are things getting better? And even having something that you can do early in the attack, whether it's trying to recognize a trigger and moving away from it, like screens, going into a dark, quiet place, hydrating yourself, maybe even using a device, something like that, and seeing, is that enough over the first 2 hours where the migraine attack seems to be waning, or does it seem to be, if anything, increasing? Once you're getting closer to that 2 hour mark, you definitely have a better idea as to whether you really need to treat or not.
Interesting. That can be challenging for some treatments that you need to treat. Like I know for myself, I'll use a device, but if I don't use it within the first 20 minutes, I've lost my window. Now with a device, maybe, it's easier, it's less expensive than some of the medications, but I wish it was simpler, right? I wish there was an easier answer. And you had this little writing on the wall that said, this is going to be a bad attack. Make sure you take your meds or your device early on. But it's not that simple. But I love the guideline that you gave. That's really helpful. Of course, if you wake up with a migraine, you have no clue how long you've had it. Unless you've been dreaming about it. For those people who don't know, you can dream about having a migraine while you're having one. Yes, you absolutely can. They're the absolute worst. I have them all the time. I'm like having this nightmare that I've got this migraine and then all of a sudden I'm waking up with explosive pain, right? It's so depressing when that happens. It really is. And of course, you don't know if you're within that 2-hour window or not. So different topic. We have a live question here, and I know we only have like 6 minutes of time left. We're actually doing really good. Just so you know, we're actually almost all the way through our list of questions, as well as all the live questions that have been asked. If someone still has a live question, I would tell you, you're going to need to get it in right away. Otherwise, we're not going to have time to get to it. So this is the question about hormonal migraine again. So what is the best way to treat hormonal migraine that is triggered by any kind of hormonal change throughout the cycle?
Be very tricky. It depends on whether you are somebody who has migraine with or without aura. Sometimes we can focus on specific hormonal treatments, and we can work with your OBGYN regarding different kinds of, whether it's birth control or an IUD that could be helpful, what would be considered safe or not. Another option sometimes can actually be trying to find the best preventive option for you. Like I said before, when it comes to weather, a good preventive medication that works well for you should be able to decrease the frequency of the attacks that are triggered, not by a specific trigger, but by any trigger.
Right, absolutely. Let's talk about that for a little bit. When you're talking about preventive treatment, how long, I know that this is a hot topic of some people, how long do we need to give a medication or a device a trial for, or a supplement? In fact, any treatment at all, any alternative treatment, how long do we need to give that a try for before saying, okay, that's really just not helping me?
It really depends on what the intervention is. So when it comes to supplements, most studies actually show that they improve things over 3 months. So it can take a while. I wouldn't give up after even a month or two. Certain medications will have a track record where they will kick in a lot faster. And sometimes if it's already been 2-3 weeks or 4 weeks, certainly, if it's not really helping that much, we might say it's time to move on. Something like the TCA antidepressants generally kick in a lot faster than most other things. It might be the type of medication that you actually have to continuously titrate up until it gets to a functional dose. So it may be that for the first month, you're actually not on anything that can be helpful at all. So it really depends on the treatment.
Right. And presumably also, it may mean that you need the right combination of treatments as well, which
absolutely
adds to the time and can make it all that more complex. And, as people who live with migraine, we know that it's very, very hard to live with this disease. And so we're all impatient. And then in this world where we are being marketed to directly by pharma, we see these commercials on TV as well. And we're thinking, oh, maybe that would work for me better. That would work for me better. But it's so important to work with your doctor and give each treatment option a good try. So I just want to encourage people to do that, not to flip-flop between treatments sooner than that, they may have worked, but you didn't give it a chance. So we have I'm going to save, there was a live question that came in, but I'm going to save that to last. So I've got 2 more quick questions before then. Let me see. I've got to cut it down because we only have room for a couple. So what is the best way to determine what your triggers are for migraine, whether that's food, scents, whatever? Is there a best way to go about that?
Observation more than anything. And it's not the most fun thing to use a migraine tracker, but sometimes it can be an amazing repository of information. Tracking is really going to be the thing that'll tell you best the kinds of attacks that you have at what times, different, patterns that you might not have recognized otherwise. It's very important.
Okay, excellent. That's going to bring me on to the next question, which is about migraine diets. I know that some of the migraine diets out there are really crazy. Some of them sound pretty good. But what is your recommendation? If someone wants to try a quote unquote migraine diet, where should they start? And is it the be all and end all of finding a food trigger?
In general, trigger avoidance has never actually been shown to decrease frequency or severity of migraine. There was a meta-analysis of all of the different migraine diets, quote unquote, that actually did not show any significant benefit with any of the elimination diets. The best evidence when it comes to food is a small study that looked at increasing your healthy omega-3 and decreasing your bad omega-6 fatty acids. And that does seem to be something that's helpful. So eating more nuts, eating more, fish, all of that is going to overall be better. But whether you're eliminating specific foods or all foods, unless you are 100% certain that that food is something that consistently triggers your attacks, it's probably not going to be that helpful.
Absolutely. And in terms of like triggering your attacks, we're not talking about craving it during your prodrome when the attack is essentially already started. We're talking about something that comes before the prodrome, which is a whole other complex thing. I know we have 1 minute left, so I'm going to give you this last question. I'm so sorry because we literally only have 1 minute for it. But what are you most excited about in the world of migraine research right now?
More than anything, actually, other targeted treatments. We know CGRP works for many people, but not necessarily for everyone. And we actually reviewed internally for all the Neura Health doctors and coaches. We do this as a journal club once a month. Great paper that came out that compared PACAP, which is one of the next treatments that's targeting, another inflammatory neurotransmitter that is, if anything, more associated with migraine than CGRP. It seems like it's going to, be, if anything, a target that would be helpful for more people, likely would be, potentially more beneficial. We'll see tolerance and, efficacy, data as, that becomes available. But I would say I'm, most excited about new treatments.
Right, absolutely. And for the PACAP, I believe that is just, it's finished phase 2 and they're looking at starting phase 3. That's about right?
That is about right, correct.
Okay, so I'm looking forward to that too. My understanding is it targets inflammation. So, wouldn't it be amazing if there was something that actually helped migraine, but also helped, other conditions you may have that are due to inflammation? I mean, that would be, maybe I'm just dreaming, but for me, that would be really amazing. So one can only dream. Well, thank you so much for being here today, Dr. Berk. I really appreciate that. Thank you, everybody here who is watching us, everyone who's going to watch this. I hope that you found this helpful. If you have any comments or questions that are not being answered in this live event, please let us know in the comments. We will come back and do another of these again at some point, as long as Dr. Berk is brave enough to do another of these open mic ones. Been thinking on his feet very fast today, and it's been amazing. But we do encourage you to proactively partner with your doctors, explore different treatment options, and create an action plan to help manage your pain. If you are looking for a different headache specialist or just a headache specialist, we do highly recommend Neura Health. They have an amazing program and some amazing doctors. And we have posted the information about that in this. And there are many people in our community who actually do see one of the doctors at Neura Health. So want to wish everybody well today. And thank you so much for attending.